Good morning teachers, seniors and batchmates. Today I am presenting article on intraductal carcinoma of the prostate. Extreme nuclear size is not a diagnostic parameter. This study was done by Himamali Samartunga et al. And this article has been taken from American Journal of Surgical Pathology published in November 2021. Introduction. Intraductal carcinoma of prostate is a marker of aggressive disease being associated with high-grade invasive prostate cancer and in radical prostatectomy specimens, disease with higher tumor volume and higher stage including seminal vesicle involvement. Intraductal carcinoma of prostate has also been shown to have a significant negative impact on biochemical recurrence-free survival, cancer-specific survival and overall survival. A large meta-analysis found that the negative impact of intraductal carcinoma prostate applies to its presence in both prostate biopsies and radical prostatectomy specimens. Therefore, accurate assignment of intraductal carcinoma prostate as an intraductal proliferation of carcinoma cells is crucial for appropriate patient management and prognostication. According to 2016 WHO classification criteria for intraductal carcinoma prostate consisted of malignant epithelial cells filling large acini and prostatic ducts with preservation of basal cells forming either 1. Solid or dense cribriform pattern, 2. Loose cribriform or micropapillary pattern with either marked nuclear atypia, that is nuclear size 6 times normal or larger, or comedonecrosis. Not surprisingly, these criteria accord with the concept that intraductal carcinoma of prostate is a high-grade tumor that infiltrates prostatic ducts, hence the preservation of basal cells. The requirement for intraductal carcinoma of prostate showing a loose cribriform or macropapillary pattern to contain foci of comedonecrosis or exhibit marked nuclear atypia with a nucleus 6 times normal size or larger is questionable. In the study that proposed the diagnostic feature of intraductal carcinoma of prostate, it is unclear as to what size parameters are being referred to, as this could relate to nuclear area, diameter or circumference, or whether this should apply to all cells present or just a portion of them. Further, no data were provided as to how this specific measurement was obtained. Despite this uncertainty, the definition has gained traction in the medical literature and was adopted into the 4th edition of WHO classification of tumors of the prostate. In this study, they have performed a series of morphometric analyses relating to the nuclear perimeter, surface area and diameter on a series of radical prostatectomy specimens containing intraductal carcinoma prostate and compared the results with the normal prostatic glandular epithelium as controls to ascertain the extent of nuclear enlargement in intraductal carcinoma prostate and determine if it is an appropriate diagnostic parameter. Materials and methods. Radical prostatectomy specimens from intraductal carcinoma prostate assassinated at Aquesta Uropathology, Brisbane, Australia between December 2019 and February 2020 were employed in the study. All cases were diagnosed by specialist uropathologists, and those cases that were reported as showing intraductal carcinoma prostate were reviewed by one of the authors to confirm the diagnosis. A diagnosis of intraductal carcinoma prostate was made when prostatic adenocarcinoma of the acinar type showing cribriform, solid or macropapillary architecture with or without comedonecrosis, filled prostatic duct or acinine structures. In most cases, basal cells were apparent on hematoxylin and eosin stain sections, although in 30 cases, confirmatory immunohistochemistry for basal cells, that is P63 antibody, was performed. Cellular features of carcinoma were recognized in the intraductal cells in 100 cases that were selected for evaluation. In these sections, representative areas of intraductal carcinoma prostate as well as normal luminal epithelium situated well away from any focus of prostatic adenocarcinoma or intraductal carcinoma prostate were also selected for image analysis studies. Cancer grading was based on the criteria of the 2005 modified Gleason's grading system and the recommendations of the 2014 International Society of Urological Pathology Consensus Conference. None of the patients had undergone hormone or radiation therapy before surgery. All the radical prostatectomy specimens were completely sampled and handled in accordance with established protocols at Aquesta Uropathology. Morphometric analysis was undertaken using a computer-assisted image analysis system. Images were captured at 400x magnification and measures of the nuclear perimeter, nuclear area and largest nuclear diameter were undertaken for each cell. For intraductal carcinoma prostate, a typical focus was selected, and in particular tumor cells at the edge of the ducts were included, as preliminary studies shows that the largest nuclei were situated in this position. For assessment of the nuclear dimensions of each case, 100 nuclei from foci of intraductal carcinoma prostate and 50 nuclei from foci of normal luminal epithelium were examined for each of the 100 patients. Results: the patients had a mean age of 67 years. The mean and median serum prostatic specific antigen levels were 8.3 and 6.7 nanogram per milliliter. The radical prostatectomy Gleason score were 3 plus 4, that is 7 in 6%, 7 in 15%, 7 with a tertiary component of grade 5 in 9%, 9 in 61% and 9 in 9% of cases. Extraprostatic extension was present in 92% of cases, and these cases had features of established extraprostatic extension in 90% and focal extraprostatic extension in 2% of cases. Surgical margin positivity was found in 29% of cases. Tumor volume was more than 3 cm cubic in 56% and seminal vesicle involvement was present in 24% of cases. Intraductal carcinoma prostate characteristics. The most frequently observed architectural pattern was cribriform, which was present in 92% of cases. A solid growth pattern was found in 29% of cases, while a macropapillary architecture was seen in 28%. Multiple architectural patterns of intraductal carcinoma prostate were found in 49% of cases, while a single pattern was seen in 51%. Comedonecrosis was present in 37% of cases and was identified in all three patterns of intraductal carcinoma of prostate. On casual inspection, cases with macropapillary architecture appeared to have larger nuclei than those with cribriform or solid patterns. When large masses of cribriform or solid intraductal carcinoma prostate were present, cells towards the center of the masses tended to be smaller than those at the periphery adjacent to basal cells. Measurements were performed on the cribriform areas in 70 cases, macropapillary areas in 19 cases, and solid areas in 11 cases. These are some of the examples of intraductal carcinoma prostate from which nuclear measurements were taken. Photomicrograph A shows cribriform pattern of intraductal carcinoma prostate. Photograph B shows macropapillary pattern, and photomicrograph C shows solid pattern, and D shows comedonecrosis pattern. For intraductal carcinoma prostate, the overall range and the mean for each of the parameters was 19 to 45 micrometer for nuclear perimeter, 28 to 136 micrometer for nuclear area, 6 to 18 micrometer for maximum nuclear diameter. For benign luminal epithelial cells, the overall range and mean for each of the parameters was 17 to 33 micrometer for nuclear perimeter, 27 to 78 micrometer for nuclear area, 5 to 12 micrometer for maximum nuclear diameter. The resulting difference in size between intraductal carcinoma prostate nuclei and benign nuclei using the means for each parameter were factors of 1.3 times for nuclear perimeter, 1.6 times for nuclear area, and 1.3 times for nuclear diameter. There were 3 patients where a small number of very large nuclei present within the intraductal carcinoma prostate. In these 3 cases, the maximum nuclear area for the intraductal carcinoma prostate cells was 135, 136 and 136 micrometer respectively. In these cases, the greatest nuclear area of tumor cells within the intraductal carcinoma prostate were compared with the adjacent benign epithelial nuclei having the smallest nuclear area. This showed the tumor cells with the largest area to be 3.6 times, 3.8 times, 3.8 times larger than the smallest benign nuclei respectively. In this same series of cells, comparison of values for the greatest nuclear perimeter with those of the smallest nuclear perimeter of benign cells showed the tumor nuclei to be 2 times, 2.1 times and 2.1 times larger than the nuclei of the benign cells. Similarly, for tumor nuclear diameter, the largest tumor cells were 3 times, 2.5 times and 2.5 times larger than that of the smallest benign nuclei. Coming to discussion, it is evident that it is difficult to assess and compare nuclear surface area and nuclear perimeter by visual inspection alone without resorting to morphometric analysis, something that is not a practical option for pathologists in diagnostic laboratories. In a discussion document, Verma et al. Pointed out that nuclei 6 times greater in perimeter or diameter would appear massive even at low power, and that nuclei of these dimensions are not a feature of either infiltrating prostate cancer or intraductal carcinoma of prostate. In reality, the features of intraductal carcinoma of prostate are simply those of a high-grade carcinoma that has invaded a prostatic duct, and as such it has been suggested that it should not be considered a diagnostic entity. The diagnosis of invasive prostatic adenocarcinoma is based on architectural features and a variety of malignant cytological features. These include abundant cytoplasm, which is amphophilic or eosinophilic, sharp luminal borders, nuclear enlargement, nuclear hyperchromasia with chromatin clearing, nuclear pleomorphism, and prominent nucleoli, significantly contrasting with benign luminal cell nuclei. In intraductal carcinoma prostate, similar cells are seen within the duct's acinar structures, displaying cribriform, macropapillary or solid architecture, but with a retained basal layer. Unlike adenocarcinoma from other locations such as colorectum, invasive prostatic adenocarcinoma usually shows only mild to moderate nuclear enlargement, hyperchromasia or pleomorphism. It is well recognized that mild to moderate nuclear enlargement along with nucleolar prominence in the absence of active inflammation are among the diagnostic features of prostatic adenocarcinoma. There is, however, no known mechanism by which carcinoma cells within ducts would develop more prominent enlargement than that seen in adjacent invasive cancer. In addition, specific size criteria of nuclei are not assessed in invasive cancer, and therefore it is not credible that nuclear size should be of such diagnostic significance in intraductal carcinoma prostate, independent of other malignant nuclear features. In contrast to intraductal carcinoma prostate, which is invasive cancer, high-grade prostatic intraepithelial neoplasia is considered to be a precursor of invasive carcinoma. While unifocal high-grade prostatic intraepithelial neoplasia is not a significant risk factor for subsequent carcinoma, multifocal high-grade prostatic intraepithelial neoplasia has been significantly associated with subsequent invasive prostate cancer. In contrast to intraductal carcinoma prostate, which is associated with high-grade invasive carcinoma, the carcinoma associated with high-grade prostatic intraepithelial neoplasia is low-grade in 80% of cases. It is therefore important to distinguish intraductal carcinoma prostate from high-grade prostatic intraepithelial neoplasia. In particular, the prominent architectural complexity seen in intraductal carcinoma prostate is not observed in high-grade prostatic intraepithelial neoplasia, which has simple architectural pattern of flat, tufted, papillated or rarely simple cribriform structures with only a few lumina without comedonecrosis. High-grade prostatic intraepithelial neoplasia has thickened epithelium with pseudostratified nuclei and cytoplasmic eosinophilia, while nuclear enlarged, hyperchromatic and crowded with prominent nucleoli. The degree of nuclear enlargement and pleomorphism is not to the extent seen in invasive carcinoma and intraductal carcinoma prostate. Studies have shown also that molecular characteristics are significantly different between high-grade prostatic intraepithelial neoplasia and intraductal carcinoma prostate. Intraductal carcinoma prostate have shown high levels of ERG expression and P10 loss, consistent with it being aggressive cancer, entirely different from high-grade prostatic intraepithelial neoplasia. Large glandular lesions that appear architecturally more complex than high-grade prostatic intraepithelial neoplasia but have insufficient architectural and cytological atypia to establish a definite diagnosis of intraductal carcinoma prostate are labeled atypical intraductal proliferations. Importantly, studies have confirmed that patients with atypical intraductal proliferations have a high risk of unsampled intraductal carcinoma prostate, and that invasive cancer in these cases has a high risk of being high-grade. In summary, this study shows that not one of the three parameters of the nuclear size that were investigated in this study satisfy the recommended criteria for the diagnosis of intraductal carcinoma prostate, which raises questions as to the validity of previous studies that have relied on these diagnostic criteria. It is apparent that although there is some degree of nuclear enlargement with intraductal carcinoma prostate, this is not massive and there is overlap with the size of non-neoplastic prostatic ductal epithelium. For this reason, the authors recommend that nuclear size be abundant as a diagnostic feature of intraductal carcinoma prostate. They suggest that the appropriate features for the identification of intraductal carcinoma prostate are similar to those of high-grade prostatic carcinoma. Definitive assessment can be problematic in needle biopsies, especially in the absence of comedonecrosis. In uncertain cases, urgent rebiopsy should be recommended as underdiagnosis of intraductal carcinoma prostate on needle biopsy can have disastrous consequences due to the delay of definitive treatment for what is potentially an aggressive malignancy. Coming to abstract, High-grade prostatic adenocarcinoma involving duct or acina structures is labeled intraductal carcinoma of prostate. As numerous studies have shown that intraductal carcinoma of prostate is associated with high-stage disease with a significant negative impact on cancer-specific survival, accurate diagnosis is crucial to ensure appropriate patient management. The definition of intraductal carcinoma of prostate recommended by 2016 World Health Organization classification suggests that cases of intraductal carcinoma of prostate with micropapillary or loose cribriform architecture without comedonecrosis should have cells with more than or equal to 6 times nuclear enlargement. To evaluate the extent of nuclear enlargement in intraductal carcinoma of prostate, they performed morphometric analysis relating to each of these parameters in 100 radical prostatectomy specimens. 100 nuclei from foci of intraductal carcinoma of prostate and 50 nuclei from foci of normal nodular epithelium were examined for each patient. Diagnosis of intraductal carcinoma of prostate was based on cells with definite features of carcinoma present within duct or acina structures. Comparing the means of each of the parameters between intraductal carcinoma of prostate cells and benign luminal cells, there was a statistically significant enlargement in nuclear perimeter, nuclear area, and nuclear diameter. However, the difference in mean nuclear size was limited to factors of 1.3 times, 1.6 times, and 1.3 times respectively. 3 patients each had rare large nuclei. For these rare cells, nuclear perimeter for one patient was 2 times, for one it was 2.1 times, and other patient 2.1 times. Nuclear area for one patient was 3.6, for one 3.8, and other 3.8 times. Nuclear maximum diameter was 3 times for one patient, 2.5 for one person, and 2.5 for other. The definition of nuclear enlargement of more than or equal to 6 times was not reached in any of their cases, all of which clearly showed features of duct invasive carcinoma. In these cases, reliance on nuclear size criteria would have resulted in underdiagnosis of ductal carcinoma of prostate. This is of concern as failure to recognize intraductal carcinoma of prostate, particularly in needle biopsies, could lead to delays in the timely treatment of aggressive high-grade prostate cancer, resulting in cancer progression and suboptimal patient oncological outcomes. Thank you.